today about the greatest influence on return to work. Who is it? Is it us doctors? Is it the workplace? Is it the insurer? Is it others? The Territory has its own special challenges, particularly with the level of remote work that's done in the Territory and that degree of geographic isolation. But you also have some fantastic advantages in the Territory, and I want to acknowledge a few sessions coming up. Pam Garton is an expert on risk factors, and so it's a real treat to have her here and someone who should be made use of in the Territory. And it's also wonderful to see NT WorkSafe developing online training. And so even though it's a small group in the Territory, there's a lot of innovation that comes from the Territory. So commend those who are actually doing great work in the Territory. All right, so I'm juggling two presentations here so I can look. We've had significant research over the last 20 to 30 years in terms of return to work, and they say good research tells you what you already know, and I think in this area that's actually quite true. So we know quite a bit now about how to foster return to work and how to get decent results from return to work. And we know that through research at the case management level, at the workplace level, and we also have a reasonable sense of what should be done at a system level. And of course, at each of these levels, there's barriers to improving return to work results. And what I want to talk about today are some of the key themes that underpin good return to work results. And the first of those is reciprocity. So reciprocity, and if you've heard me talk before, you might have heard me talk about reciprocity, but that's that concept that you grew up with. Your mum said, you know, do unto others as they do unto you, etc. And so if your next door neighbour wants you to help out building a carport, you really want to have a good relationship so that you'll say no. That you'll say and really stick it to them. So you want to have that really good relationship. If you treat people well, they are more likely to, in fact, respond well. This is the most widely studied facet of human nature across societies and across history. So that sense of how you're treated makes a huge difference. And there are kind of two types of reciprocity. There's positive reciprocity. So if I do something good for you, studies say you are more likely to do something good for me, and in fact you're going to up the ante. If I do something bad to you, you don't trust me, and you will respond the same way, except you're probably going to have not just better reciprocity, but you'll have worse reciprocity. You'll have worse response. So you'll respond in kind, but more negatively. And the people who tend to respond to negative stuff is often the people who are perhaps a bit difficult in the workplace. They're perhaps not the best performer. They might be a bit negative in themselves, and then you do something, or the supervisor does something, and then they feel free to respond negatively in kind. So that's an important facet. And then the other underpinning principle I want to talk about today is social capital. And this is the concept of the amount you save by having cooperation. And the studies from this come from Italy, North and South Italy, where quite different environment. But social capital, if you have good trust in each other, trust the workplace, trust your insurer, then there's much less requirement for administrative tasks, you know, making written agreements, there's much less disputes. And so that social capital then translates into a much more harmonious environment where things tend to run more smoothly. And many of you might have worked in some organisations which have a really positive culture versus a negative culture, and you'll see the differences: staff turnover, sickness absence, etc., etc. So now I'm going to turn to research. So they're the underlying themes I wanted to talk about. This slide up here is the summary of a series of reports that are on the Safe Work Australia website. Excuse me. This is the data from the Safe Work Australia website. So I was in the fortunate position of analysing the Return to Work survey. That's a national survey done every 2 years, although in future it's going to be every year. It used to be run by the heads of Workers' Comp, now Safe Work Australia, and it interviews people around Australia, about 9,000 in this sample, it was a 2-year sample, and I was asked to look at the difference between psychological and physical cases. Now, there's 2 long reports on the website, the Safe Work Australia website, but the short summary of all of this is here. And what it says is, so the survey asks people about their return to work outcomes and their return to work experiences. So how were they treated? How did they feel that their employer responded, the system responded, etc., etc. And what I've done is group questions or group answers together. So there's a whole bunch of questions about the workplace, or there's a whole bunch of questions about how the doctors dealt with them. And so I've grouped those together to analyse the data, because there's about 270 variables or in this questionnaire. And so grouping them all together and then looking at positive versus negative. So let's say there are 6 questions about how your employer has treated you after you've reported your injury. So putting all those together, which you can do statistically, we can look at people who say their employer was positive and constructive versus those who don't feel that way. So if the worker says, my employer has been constructive and positive via these questions, there's a 42% higher rate of return to work. It's a huge difference, yes? Surprise anyone? Surprise you? Not surprise you? Haven't put your hand up? All right, so that's with physical cases, and if the employer responds positively, the difference with psychological cases is 65% higher return to work rate. That's magic. That's really huge difference. Early contact, so the workplace rings people up and says, hey, I heard you had an injury, how you doing? Contacting early versus not making any contact, 26% difference and 63% psych over here, and on it goes. So these green shaded areas are where the employer can make a difference. This is the system and case management in the claims environment. So a dispute, no dispute, 22% higher return to work physical and 31% psychological. Lack of concern, a lot of people, you'd be surprised how many people are concerned about lodging a claim, in the order of 20 to 25%, and people are worried they're going to be treated differently, they won't be believed, etc. Pretty amazing statistics, really. And if you're not concerned about lodging a claim, you've got a better return to work, which may well be the employee's anticipation of how their employer is going to respond. Positive interaction with the claim system, 25% better return to work. Workplace culture, on it goes. Personal resilience makes a difference. Interestingly, because I looked at the data by jurisdiction, even though that's not published, interesting, personal resilience as it's measured in this validated questionnaire is lower in the territory than elsewhere. Medical care focused on return to work, that's us doctors. So the questions in here, and there was some question about how the people were surveyed with this, but you can see us doctors don't make a huge difference. Not a surprise really when you think about it. So when doctors are focused on return to work, as per the questions, there's an 8% better return to work rate. Psychological, you'll see there's no data there. The sample size was really too small to analyse that. So I want to talk a bit about implementation today. We talk a lot about innovation. Whoops. We talk about innovation, and there's a lot of discussions about innovation when it comes to insurance these days, data analytics, AI, etc. But really, when it comes down to it, return to work is the basics. Innovation can help and can make us more efficient, but the core of return to work is people and that interaction with people. So, and we have systems that cover many of these things, but I think we are not yet there in terms of how well our systems are implemented and how consistently they're implemented. So I just want to use the analogy of, let's say we want to get size 9 socks on the shelves at Target, or it could be Kmart. So we want to get the socks on the shelves. If you think of all the people that are involved, there's manufacturing in China, there's, used to be Victoria, now it's China, there's getting the goods across here, then there's, you know, road transport, there's the cleaner at Target, there's the person who's making the purchasing order. There are all these things that have to happen to get those socks on the shelves. And I don't want to give you the impression that I'm thinking people are socks, but we really have the same issues when it comes to return to work. We need all of our systems working. If there is one gap in the system, we don't get, we have a significantly higher risk of not getting a good outcome. So if we look at systems and implementing systems across the scheme, vaccines is another good example of implementation. So if we look at vaccines around the world, our challenges, innovation and getting new vaccines, that's important. But really, some of our biggest challenges with vaccines are implementation. How do we get the polio vaccine into the highlands of Pakistan, where we've got to get cold transport and we've got warring factions? How do we get people of inner city, Melbourne or Portland, America, to have good understanding of vaccines and not be following misinformation? So a lot of that is implementation, and it's the same with return to work. Now I'm going to talk a bit more detail about the workplace, because I've highlighted on that first slide that the workplace is where you can make the biggest difference. So let's talk about the research. Well, there's a major review done by the Institute for Work and Health Group at Monash University in Australia in conjunction with the Institute for Work and Health in Canada. And basically what their review, huge review, massive review of the research says that if you have multi-domain interventions, i.e. working on work, service, case management that is, and health, you have the best outcomes. Well, I think we'll be sharing these slides, won't we? And so there's lots of references through the PowerPoint if anyone has the slightest interest in chasing the research. Thanks. Wrong button. So that's the big major review. Now I want to talk about 2 studies that have been done at the workplace. So these are interventions that have been set up on a large scale across multiple workplaces. The first one I was involved with, and it was a system we ran from Victoria. A lot of it was telephonic case management, and we worked with big companies, Visy, district nurses, aged care facilities, manufacturing. And we had a strong focus on getting reports in within 24 hours. We would have the supervisor and the worker, so the worker would go to the supervisor and report the problem, call up on a 24-hour hotline, and that enabled us to start from the beginning and influence how the case was going to go. So early reporting, avoidance of disputes, we probably out of about 5,000 cases disputed 4 or 5, and I can tell you they're the ones that went badly. About half of those went badly. So we rarely disputed, and often when there was a dispute, only as the months and months came on, you would learn more and more about the case, and we realised perhaps we shouldn't have disputed it in the first place. We had strong involvement from supervisors. We had supervisors forever saying, oh, you can't just accept all claims, you'll have an avalanche. And gradually they came round. We had lessons for them. We taught them about looking after people, and you know, after a while, yes, we're loving them. Yes, we're loving them. The supervisors would get into the routine of looking after people and caring for them, and that was a big part of the program. Skilled case managers, and because we had some medical involvement, we had the ability to help doctors and try and streamline care. So let's just say get the MRI of the knee day 2 when it's big, fat and swollen, instead of waiting for a month or 2. And the results of this were that we had a 60% reduction in days lost from work. So there was a control group. So this is the average days lost from work per claim before we went on with these companies, and this is afterwards. So you can see that's a significant reduction in days lost, and there was a reduction in days lost from the control group as well. That is the group where this intervention didn't take place. And claims costs were also down. It was about a 40% reduction in claims costs. And obviously in the control group, a slight increase, which is probably inflation. So the messages I wanted to give you from this were, it really is possible and practical to make a difference at the workplace by altering systems and making sure those systems are functioning well. The challenges we had finding good quality case managers, I think we generally underestimate the difficulty of being a case manager. It's a hugely difficult task, and keeping people in the role and upskilling them is an important aspect of getting systems right. So the second implementation study I want to talk about is in Sydney. So Gary Pearce was a rehabilitation physician who's sadly no longer with us, and Gary started this intervention program at Concord Hospital, and Professor Michael Nicholas, who's a pain specialist, has taken this to the next level. So this is now implemented across a range of public hospitals in New South Wales. It's not yet published, but Michael has kindly provided permission for me to use his data. And so they had a slightly different model than we used. Their focus was on identifying risk, and they used the Arebro musculoskeletal pain questionnaire for identifying people at high risk. So what they found was, or what the setup was, is when somebody was of high risk, as measured by the Arebro, they then upped the ante and provided a greater focus on the case and greater support levels for the case. So people were offered going to see a psychologist. Now you might think, oh, well, that's a bit odd, you know, the person's only been off work for a week or two. You know, there's no evidence of psychological problems. But what they found was there was a reasonable take-up of that, and people who adopted that actually found it really quite useful. They learned simple strategies. It might have only been 2, 3 or 4 visits to the psychologist, but they learned simple strategies that help them with their confidence and how to manage their situation. And this is the result. So this is actually the costs per month, and you will see again there's a control group. So the control group are people who weren't involved in this, and they were other public hospitals within the Sydney environment. And so this is looking as the claim goes on by months. And what you'll see here is in the early stages with the intervention group, there's some slightly higher costs early on. But over time, what you'll see is that the costs then peter out for the intervention group, and the control group, the blue, are still incurring quite a lot of costs over time. And of course, we know that our long-term cases are the most expensive ones. This is looking at the days lost from work. And you'll see that while it doesn't look as dramatically different, you'll see there's a lot more red lines here than blue, and that is representing a much lower rate of long-term disability in the intervention group. Well, that's all very nice, you say. We know we can do it. Well, where are we at? And so this is really just a graphical version of what I showed you earlier, that if the employer is positive in their response, a much higher rate of return to work for both physical and psychological cases. And yet, where are we? Well, if we look at, these are the questions that made up how your employer responded. I'm going to keep doing this. So if the worker said, my employer did what they could to support me, made an effort to find suitable duties, provided enough information and treated you fairly, then that was a positive response from the worker. And you can see here that 75% of people actually advised a positive response from their employer if they had a physical case, and only 27% of people with a psychological claim felt their employer responded in a constructive and positive manner. And that's repeated through the survey. You'll see that people with a psychological injury claim feel they are treated differently. Dr. Peter Cotton was a clinical and organisational psychologist, also sadly no longer with us, but Peter was a national figure and talked a lot about these issues and how the importance of treating people with a psychological claim following the same processes as a physical claim, but we don't tend to do that. So contact after injury, you'll see here that 58% of workers who have a physical claim say their employer made contact with them. So, and 47% made it within 3 days, and 53% within 10 days. So you can see there's a lot of people who are reporting an injury who don't feel their employers made contact, and that's even more so with psychological cases. This is just saying that if you're contacted early, higher chance of return to work than if you're contacted late. This is looking at people who say that the system, the case manager, the claims manager they have dealt with has been positive and constructive in their approach. The process was honest, various good communication, system was working to protect my best interests, treated me fairly, helped me with my recovery. And you'll see that when people say the claims person they've been dealing with has treated them fairly, significantly higher rates of return to work. You might just say, well, people who go back to work may be just more positive people, and that's what you're seeing in this data. But we don't see it in some areas, like there are different questions, say under financial stress or how doctors deal with them. It isn't universal that the people who are positive are responding positively. So I think there's validity in those results. So we've talked about the workplace can make a meaningful difference. And I've talked to you about how us doctors don't make a huge degree of difference. Just to look at that in a bit more depth and nuance it, actually us doctors in this other study, which is a study that follows people forward over time, says that us doctors actually do make a difference, but it's in that first 3 to 6 months after injury. And if you think about it, that makes sense, because that's when medicine is more relevant. But once we get past about 3 to 6 months, our influence makes less of a difference because it's really the psychosocial factors that are playing a major role, and we're not terribly good at addressing those. We do our best, but we're not good at addressing those psychosocial factors as a generality as doctors. And so we make a difference in the short cases, but in the longer term, it's the return to work coordinator or the person at the workplace that has a much greater impact than us treating practitioners. And there's just some research if you're interested to understand more on that. I've talked a lot about, so I've talked to date about the workplace, and hopefully I've given you a sense that the workplace is really the place that makes the major difference. And we're going to delve into this in more detail in the workshop this afternoon, where we'll go through some of the key systems at workplaces that make a difference. There's about another 5 to 10 minutes in this talk, and then hopefully we'll have time for a bit of a discussion after that before the next session. So when we talk about claims management, and I should say that claims management in the territory, if you look at claims management across Australia and what workers say, claims management in the territory is a bit lower than other jurisdictions in terms of what workers say about the support they get. So that's why it's particularly good to see NT WorkSafe looking to upskill claims and claim staff and insurers, because there's a big difference that can be made there. So what we know from the research about claims management is to try and avoid delays, avoid disputes, and avoid disharmony. There's much less research about effective claims management within an insurance environment than there is at the workplace. The other thing that I think we are fairly clear about now is that identification of high-risk cases is at a point where we really should be adopting this. How we adopt it is another question, and Pam will talk more about risk factor identification. I won't talk more about identifying high-risk cases now, because Pam's going to be doing that in more detail. But suffice it to say, I think it's a really important development over the last 5 years, and increasingly it's becoming systematised at an early stage. Different insurers and different groups are adopting this in different ways, but it's certainly an important tool. This is from another one of Michael Nicholas's papers, and so this is looking at the Erebro in New South Wales, and showing you these are the high risk people, and this is the a number of days they've been off work or paid for being off work, and this is low risk. So just eyeballing it, you can see it's quite a differentiator. So bringing it all together, if we want to improve return to work, and we do, as occupational physicians, we see the end result of poor return to work outcomes. My penance in Victoria for being a constant complainer about the Victorian scheme is I now see mostly people who've lodged common law claims, and it's a very unhappy group of people. They've been on the system for 3 or 4 years. Common law focuses on blame, and so it's a very demoralising group of people to look at. But the health of that group really, they're angry, they're upset, their kids' health is affected, their whole lives are disrupted, they've lost their identities, and many of these situations have come about through things that could have been prevented. You'll hear people in this situation talk about what their supervisor said day one, and it might be simply that the supervisor was indifferent or nonchalant or not civil to them. And that process has then started from there, and then maybe they've been back on restricted duties and then they're withdrawn, or maybe they've never gone back to restricted duties, or maybe they've gone round in circles and there's been 3 or 4 conciliations or disputes. And so it's very damaging to people, and the financial costs are massive. So the financial and human costs tend to run parallel, not always, but they often run in parallel. So this is my individual or semi-scientific view about if we want to improve return to work. These are really where we can get the best bang from the buck. And you'll see, obviously, the quality of the workplace response is key. Claim lodgement systems, can you lodge by phone? Can we start the ball rolling as quickly as possible in terms of intervention and helping people? Procedural justice in decision making and return to work coordination are probably the key areas where I think we can make a difference. And we're gradually getting there. Policy is the art of what can happen and what can be implemented. And over 10, 20 years, we are seeing groups gradually move across towards really addressing psychosocial factors, but we're still a way to go. So the challenge, I think, is we have, around Australia, we have all sorts of meetings discussing innovation and various aspects, but we really very little discuss implementation. So if I think of case management, when I listen to people around Australia on case management, if we're talking about in the claims environment, I'm hearing case managers have got, at times cases over 100 cases they're dealing with. Or in some environments there might be turnover of staff of 20 to 30%. We're talking about really major issues that impact implementation. How can you look after people and have continuity of care if you've got such high turnover of staff within the claims environment? And that happens in jurisdictions around Australia. Implementation research is actually quite a lot harder than just doing studies to understand what's going on, and we have a dearth of that. And skills training and development, and I've mentioned that a few times. I think that many schemes really have been in operation for a long time and are not necessarily thinking about first principles. And again, hats off to NT for developing material that will help upskill your workforce. If you upskill your workforce, you not only have them more likely to stay, you have that group more likely to do better work and also then train others who are new to the field. So I think our challenge for the next 10 years is really an implementation. That's all I wanted to talk about today, but it'd be great to have some questions or